So now when you're done with the vascularization, probably the revascularization, now there are some considerations you need to have in your mind, which is when you have to decide if this segment of the bowel is resectable or it's viable. So what you do is you do the vasodilators, like in the form of infusion, or you can directly do into the artery, give papaverine, which is a vasodilator, and then allow 30 minutes to assess the bowel viability. So the primary markers is like the peristalsis, if there is presence of peristalsis. The color of the gut is pink, or there are palpable arterial pulsation. So that means that that segment of the gut is viable. And the other thing, if you have the possibility of doing the probing, ultrasound probe, so that can be very much helpful. Or you do the IV fluorescent followed by the Woods lamp exam. I have already shown you the picture in the couple of slides before, in which there was fluorescent testing as well. So you can use all these methods to assess the viability of the gut. Okay, so for non-viable looking bowel, what you do is, like, if there's a frankly necrotic bowel segment, do the resection. Or if the marginal bowel is involved and rest of the bowel is viable, then that can be possible. That may improve over hours, and then you can go for a second look laparotomy. So obviously, in a second look laparotomy, you have to do the temporary abdominal closure. That's a kind of a damage control surgery. So remember, if you're confident and you have a frankly necrotic bowel segments, go for the resection. And if the marginal segments of the bowel are viable, then maybe possible you're also giving the heparin and your vasodilators, and you have restored, you have done the embolectomy, and the consequences may improve over the years, and then you can go for a second look laparotomy. But sometimes it's possible, if a patient is coming to you and if he doesn't have a history of atrial fibrillation or any kind of ischemic heart disease, coronary artery disease, heart arterial fibrillation, any kind of positive history regarding the acute mesenteric ischemia, and then you do the laparotomy, and on laparotomy and on the clinical examination, patient wasn't that tender, no sense of peritonitis, but you decide to do the laparotomy because of severe sudden abdominal pain, and you don't have time to go for the angiography, and you have opened up the patient, and you see that a large segment of the gut is involved, and you have done the you have done the resection, and then you have done the primary anastomosis, and after the primary anastomosis, just admit your patient to the ICU care, and just see for the activity, if the patient has started passing the flatus or stool or anything like that, and observe your patient. And if the patient is stable, you can go for the CT angiography later on, because in such patients which doesn't have any obvious signs or history, or no atrial fibrillation, no infarction, no mural thrombi, no vegetations, no history of hypertension, diabetes, trauma, anything like that, then you can do the resection and primary anastomosis, and after that you can go for CT angio. But usually it's recommended that if you are doing the laparotomy, do the revascularization, do the embolectomy or graft. Most of the time embolectomy is done if the arterial thrombosis form, but in case of the chronic, you do the bowel resection, you do the grafting, and then you decide for the bowel resection, and you assess for the viability of the gut, wait for 30 minutes, give the vasodilators, maybe in a catheter infusion, then you can assess the viability, and depending upon the assessment, do the resection or primary anastomosis. So that's all for today. We have been talking about acute mesenteric ischemia, the presentation, the role of the investigation, and definitive points for the resuscitation, pre-op management, and what important step you have to do the intraoperatively, the role of embolectomy, the bypass grafting, and bowel resection. Thank you for watching sqadia.com.